The tools for skin perfusion are helpful, validated in clinical practice. I have the unique opportunity to work in 4 different universities on 3 continents, and I see how differently these tools for clinical assessment of tissue perfusion are used and implemented in clinical practice, and that's really fascinating. For this presentation, there are no conflicts of interest because, as of now, most of the industry is not interested in skin perfusion yet. Well, skin perfusion is nothing new. Let's say the recognition that abnormal skin perfusion is something that is not really good. That's nothing new at all. This is 1806. That's a long time ago. And they painted the Battle of Trafalgar, where Lord Nelson died. And at that time, of course, you died of trauma, penetrating injury, so probably hypovolemia, hemorrhagic shock, and oh, I'm going the wrong way. And look at the face of Lord Nelson. It's very white, and there should be no, that doesn't work. So it should come out so you can see it more clearly. But as you can see, the I don't know if the cursor works. Yeah. The face of Lord Nelson is very pale and white, where these are bright red, and this is bright red. And of course, the painter was not there. They told him. And so later on, he painted this, and they recognized that if you die, you're very white and pale, whereas if you're normal and surviving, you're very red. I mean, exaggerated a little bit, I think, but still. So this is 1806. That's a long time ago. Max Harry Weil was the founding father of critical care, and he also recognized that the periphery was one of the windows that we have to assess inadequate circulatory function in critically ill patients. He said there are basically only 3 windows, as we described when he died as a tribute to him. Alternation, so brain function. And then the skin, either cold or clammy or mottled or whatever characteristic, but the skin is a window of circulatory adequacy. And then, of course, oliguria. Oliguria is much more difficult than we think, but if you urinate and you stop urinating, that's a bad sign. If you don't urinate, you increase blood pressure or give fluids, you start to urinate, that's a good sign. So in let's say changes like that, it's very useful. And of course, Max Harry Weil's favorite, the increased lactate levels. And these 3 things, these windows and the clinical presentations, so blood lactate levels, altered perfusion, and of course arterial hypotension is still a main characteristic of circulatory dysfunction. These 3 are on top of the microcirculation because why else would you have organ failure? Why else would you die if your microcirculation is completely normal? How would you develop multiple organ failure and organ injury? So the ultimate target of your circulatory dysfunction is, of course, the microcirculatory abnormality and the inability of the system to adequately bring blood flow to the microcirculation. So that's, let's say, the basis of circulatory shock. Our postdoc, he did his PhD last year. Alessandro Lima from Sao Paulo did a review already a long time ago. This is 11 years ago, where we looked at the tools for peripheral circulation and especially the non-invasive monitoring, because that's an attractive element of peripheral perfusion. And he said, well, there are basically 3 elements. The clinical assessment, you can feel, you can put your hand on the patient and value whether it's cold or warm. You can do a capillary refill time. I will come back to that later. You can do it somewhat more complicated and start to measure skin temperature, like Max Harry Weil started, great toe temperature, or a difference, central to toe temperature difference. All these are, of course, influenced by room temperature, so maybe biased. And therefore, maybe the proximal to distal, so a temperature probe here and a temperature probe there. And this is very well validated to be related to blood flow. And then you have the optical monitoring, like the perfusion index that you find in Philips monitors and Massimo monitors, near infrared, hardly available anymore. And then you have the OPS, the SDF, or the new one, the new generation, the cytocam, to actually visualize the microcirculation and look at it. That's very attractive because it's non-invasive, it's relatively simple, it's related to very basic pathophysiological principles like vasoconstriction due to hypovolemia, sympathetic nervous system activation. That's a very active system when you want to compensate for inadequate circulation, and a very nice window is the skin. If you do a dynamic approach, I won't talk about this, but you can even test the ability of the system to respond to an insult, like a vascular occlusion test. The correlation to outcome at that point, when he started his PhD, was relatively unclear, and the response to treatment was unknown at that time. This is something that we are very fond of in the Netherlands. Look at skin perfusion, and especially for a very long time we are, let's say, used to bolus nitroglycerin. If you have legs like this, then we bolus nitroglycerin. And Jan Bakker told me how he got interested in the microcirculation when he was rounding with the intensivist in Amsterdam, that the first thing that they would do when they came into the room of a patient, something I do as well, is first thing you do is put the hand under the sheets on the patient and feel temperature. And he was wondering, what are you doing there under the sheets? And so that's something that we are very accustomed to. And we never did any research up until Hafid from France did a study where he actually, let's say, calculated or made a score related to the extent of this discoloration. And he found when the whole leg, or almost the whole leg, is discolored, your odds ratio for mortality is 74. That's a significant mortality. And the nickname for this in the Netherlands is a discoloration of death. And so that's correct. I mean, if you see something like this, your patient is on the edge of dying. Now, not many patients have discolorations like this. Hafid just submitted a paper where he had 37 patients, where only 10 patients had this knee discoloration, so it's not very common. But abnormal capillary refill time is much more common. Also very simple to do. You press the index finger for 15 seconds, and so the nail bed becomes very white. Then you release, and then you look at the return of the color in the nail bed, and you count 1, 2, 3. If it's more than 4 seconds or more, it's abnormal. That's how we use it and validate it in clinical practice. Then your chances of morbidity and mortality are significant. It's very well to use it even in people that hardly know how to do it. This is a study Michel van Genderen did. And he asked nurses to do a capillary refill test, and he asked the intensivist to do it, and then they did it themselves. And these are the PhD students that we said, well, okay, these are the reference. And if you then look at the kappa between these three groups, and we use 5 seconds for the nurses and the intensivists, because every room in the ICU in Erasmus has a clock, and it's very easy to see 5 seconds. It's somewhat more difficult to see 4, but 5 is a very distinct, let's say, distance on the clock, and so we use 5 seconds. You find a kappa of 0.85. That's very good. And so inter-observer variability is not that big. Not as big as we thought about 20 years ago, and basically abandoned capillary refill time. Hafid also did a study in these areas where there is mottled skin, and he measured the capillary refill time in the index finger and in the knee. And as you can see, the area under the curve for mortality was almost similar, somewhat better in the knee than in the abnormally perfused areas than in the index finger, but the area under the curve was quite good. And what you see or what you feel in the skin is also related to your macrohemodynamics. This is a study by Kaplan. And what he did, he put his hand on the patient, and if he thought it was cool, he said, this is cool. And if he thought this was warm, then it was warm. And so he had two groups of patients, warm, cool. And then he measured the hemodynamics of these patients. When you were cool, you had lower cardiac index, lower pH, lower SVO2, and higher lactate. And so a very simple test. Put your hand on the patient. If the patient is warm, that's a completely different patient than when you think he's cold. Well, it seems as if this is very subjective. And when Alessandro did his first study for his PhD thesis and went into the room of patients, after the intensivist and the nurses said the patient is stable, we won't do anything else, then wait for recovery. Then Alex went in, put his hand on the patient. 15 seconds later, he came out, he said not good. And when Alex said not good, it was not good. We had a stable patient with an odds ratio of 7 to increase his organ failure. Later on, with increased mortality, I will show you. So within 15 seconds, he came out and said, this is not good. Maybe you think it's good, but it's not good. And of course, we didn't believe him. And so we did all the, let's say, objective observations. So here you can see we measure skin difference. We measured the central to toe temperature difference. We did the PFI of the, at that time, the Philips monitor. And so whenever Alex said, this is abnormal, so this is cool, all the objective measures that we took from the patient, the temperature and the PFI, were also abnormal. So it's a very simple measure that is validated by very objective measurements of temperature. And this simple measure of skin temperature or capillary refill time in this case, or the skin temperature difference, is also valid even when you cool down the patient. And cooling down the patient will induce vasoconstriction in the skin. And so even if you induce vasoconstriction, there is still a difference between survivors and ultimate non-survivors. This is where do we cool patient, post-cardiac arrest, of course. So this is the study that Michel van Genderen did in post-cardiac arrest. And even during the phase of cooling down, there was a significant differences between patients that ultimately died and patients that survived, where they had both, of course, abnormal peripheral perfusion due to the hypothermia. So it's a very relevant sign of, let's say, trouble. Now, in post-surgery patients, mortality and morbidity is not that high. And so we went to a group where you expect much less signal, let's say a signal of trouble, and studied whether capillary refill time and the other parameters are still informative. And so we did a very simple study. Surgery, we measured all the parameters before surgery and then on admission to the ICU in the next morning. There was no mortality in this group, so we defined, let's say, negative outcome as complications. And so resurgery was a complication, a long time on the ICU was a complication, and of course organ failure hardly occurred, but that's also a complication. If you came to the ICU out of the OR after elective surgery and your capillary refill time was prolonged, you had a significantly higher chance of developing complications than when you came in with a normal capillary refill time. Or, and let's put it the way we found it, what we found is patients that develop complications had longer capillary refill time. I should not turn it around because we didn't study that. And so the patient that developed complication came in with prolonged capillary refill time. And the same for the next day. Patient that developed complications had still a prolonged capillary refill time the next morning. So it seems as if having an abnormal capillary refill time when you come in is not good. We just finished a study in Chile that is submitted, and Barbara Lara did a study in 100 patients admitted with infection, and there was a clinical indication to give fluids. There was increased lactate, maybe there was discoloration of the skin, there was hypotension, there was no urine output, or the patient was let's say, subjectively dry or vomited for a long time, but there was a clinical indication to give fluids. They gave on average 1.7 liters, and we measured peripheral perfusion after the fluid resuscitation. If after this simple fluid resuscitation, your capillary refill time was 4 seconds or more, your mortality was 50%. Half of the patient died. If it was normal, 9%, almost 10% of the patient died. A huge difference. And this is what we found in all the studies that we did in Erasmus as well. You could say, well, this is a developing country, they don't have resources, but in Erasmus, it's not different. If you're admitted to the ICU with abnormal capillary refill time and it doesn't normalize, 40% of the patient die. If it normalizes, you're okay. Then you have the average mortality of the ICU, 15%. And you can use this in clinical practice as well. That's what Michelle did. That's the last slide. If you have a clinical problem, lactate doesn't come down, you have hypotension, the patient doesn't urinate, all these problems that we give fluids, usually. And the aim of the protocol was, okay, if you have this clinical problem but your periphery is normal, you're not allowed to give fluids. You can do whatever you want. You can increase norepinephrine, you can give furosemide, but you're not allowed to give fluids. And so a fluid restriction based on peripheral perfusion, he found that the protocol like this improves organ failure and not associated with problems. And so it's safe to restrict fluids when your periphery is warm, although you have a very relevant clinical problem. Together with Hafid, I wrote this Understanding the Disease, and we said, well, the use of peripheral perfusion parameters as guidelines is very promising. We have a lot of, let's say, association studies where we associate the abnormality with a clinically relevant outcome, but we don't have any interventions that tell you that if you do this, then the patient outcome will be better. So in conclusion, peripheral assessment of the circulation by use of these semi-subjective measures is very easy, incredibly fast. It's related to mortality, it's related to morbidity, it's related to mortality, and it identifies in the emergency department a group of patients that absolutely needs more follow-up because they have this huge mortality after resuscitation.